Illness. For the state level affiliate of the National Alliance of Mental Illness. So our goal is to create a world where uh, people have better mental health, where there's more supports for families, where there's opportunities to advocate, and hopefully, an event like today helps spark that in you all. You feel like this potentially is a career path for you all, and that mental health is something you can take action in. Uh, we'll just do. We'll let our panelists introduce themselves as we get going, but I just want to welcome uh, Tracy Wilson, Elizabeth Breyer, Brett Harris, and Derek Coy, who will all be uh, speaking today. We'll jump right into the questions. The first one goes out to Tracy Wilson. You were an alumni of UAlbany. Can you share what your career path? Can you share your career path that led to mental health policy?
Sure. Do we want to do some quick introductions?
You know what? Why don't we go ahead and do quick introductions?
Okay. So,
Yeah,
yeah. Hi, everybody. I'm Tracy Wilson. I'm the Chief of Staff for our Executive Deputy Commissioner at New York State Office of Mental Health. And as James said, I previously worked for a period of time at the New York State Executive Chamber. Do you want me to jump into my question or pass it to somebody else to introduce?
Um, why don't we go around and do quick
Okay.
introductions first? Liz, you mind doing your introduction now?
Not at all. Hi, everyone. My name's Liz Breyer. I also work for the Office of Mental Health. I'm the Chief Advocacy Officer and the Special Assistant to the Commissioner. Derek?
Hi, everyone. My name is Derek Coy. You can call me D. I've been at the New York Health Foundation for almost 10 years now, heading up our veteran-specific work, and happy to chat with you all a little bit more about that later.
Hi, everyone. I'm Brett Harris. I'm a principal research scientist at an organization called NORC, and I do wear multiple hats. So I'm the president of the New York State Public Health Association, which is the state affiliate of the American Public Health Association, or APHA, and I'm also a clinical associate professor at the University of Albany College of Integrated Health Sciences and the public health side of that. And just going along with two other of the panelists, I used to work at the Office of Mental Health in the Suicide Prevention Office.
Great. Thank you all for sharing. I'm the odd man out. I work for the state, but I didn't work for OMH. Uh, so we'll jump right back into to our questions here. Tracy, like we just said, you're an alumni of UAlbany. Can you share what your career path looked like after UAlbany?
Sure. Oh, sorry, it looked like I froze for a second. I graduated from UAlbany with my MSW and also attended UAlbany for my bachelor. And after leaving UAlbany, well, I should say my focus at UAlbany was on direct practice. My intention was to be a clinical social worker. I am a clinical social worker. And I did that work for quite a while. After graduating, I worked for Albany County in a couple of different roles. I worked at the Albany County Mental Health, doing some case management and collaboration with Department of Social Services. I then worked at Albany County Probation as a probation officer that carried the mental health caseload, which I just want to say for anybody who has experience or maybe doesn't have experience with probation, a good probation officer is like a case manager, and really that is what probation should be like. So with the mental health caseload, it was very much a case management type of position. I worked at the VA with homeless veterans for several years and then transitioned to the state with Office of Mental Health, where I've been for about 13 years now, I think. Um, I've worked in a few different roles within the state, within Office of Mental Health, in state and child adult services, working with our state psychiatric centers. And then I was able to transition to a new program that was a governor's initiative a few years back in 2022, overseeing the homeless support unit at OMH, which was something very new that OMH hadn't really done before, and launching the Safe Options support teams or SOS teams. It was something very high profile, and allowed me to collaborate with a lot of different levels of local and state government, and really set me up for the ability to then transition over to executive chamber for a period of time when they needed an interim assistant secretary for mental hygiene. So I spent about 7 months over at executive chamber, really learning as much as I could about policy making, and then was able to return into this chief of staff position and take all of that knowledge and apply it to the role that I'm in now.
Terrific. Thank you so much. Move on to our next panelist, Liz. You were an advocate before getting into government. Can you share a little bit about what your career path has looked like?
Absolutely. Thanks, James. I would say that I'm still an advocate working in government. And the reason why I say that is because, for some context, I'm a person who openly identifies as a person having lived experience of mental health issues and at different times in my life, substance use issues. And so I had a non-traditional trajectory right out the gate because I was dealing with mental health issues going back into early childhood. So I didn't even get to college until I was in my mid 20s. And I think I remember I took an abnormal psych class, and that was when a lot of lights went off for me internally about some of my own things and some things for some family members. And I kind of got pulled into really being interested. I wanted to be a therapist for a long time, and I was on that trajectory, actually. I was planning on doing counseling, and then I sort of switched over to social work. And while I was, working on my degree, it took me 11 years to get my undergraduate, full disclosure, taking a class here and a class there, trying to balance it with working full time and also just managing my own mental health issues. Um, I had some somewhat public things happen to me on the job, which sort of pushed me out, before I was ready to really talk about those things. And because of that, I wasn't a huge fan of the way I was being treated once I didn't have any say about people knowing my business like that. And then I discovered that there was a community known as the peer community of people with lived experience who were using that experience as a part of their roles, as their jobs and their advocacy. And I haven't really looked back since then. So I went from running traditional programs, day treatments, to switching over to peer run programs. At the time, I was working in the state of Florida. I was overseeing a drop-in center and the first warm line actually in my area of the state, and a respite house and a few other programs. Went from there to NAMI. Actually, I ran a NAMI affiliate in Florida for a couple of years, and then decided that I was interested in furthering my education. So I left Florida and came back to New York and ended up getting a master's in health advocacy from Sarah Lawrence. Right after I graduated from that, I was working in a very small family-run nonprofit and saw the an opportunity to come and work for the Office of Mental Health. I was doing a lot of work with them anyway through this nonprofit. So this is my second time working with the Office of Mental Health, and that first go around, I was working out on Long Island in one of our field offices, sort of supporting those roles. Left again, moved to a different state. I've moved around a lot in my life. My husband and I needed to move to a different state, uh, to be closer to his children. And I ran some wellness centers with a very large peer-run organization in New Jersey. Came back to the Office of Mental Health, and now I'm sitting in the role of the Chief Advocacy Officer. So I oversee a department that is primarily staffed by people who openly use their lived experience as a part of their roles, which is why I say I haven't stopped advocating. You're advocating for yourself. I'm a step parent to a young adult with also pretty significant mental health issues. So I'm advocating as a parent. I have family members. I've not stopped advocating, James, not once. There's room for advocacy everywhere.
So shouldn't have said you're an advocate before you got into government. Never stopped.
Yeah, I've never stopped, never stopped.
Uh, next we're going to Brett. Like you said at the beginning, you wear many hats, including one here at UAlbany. But can you share a little bit about how one of your hats, public health, overlies with the mental health system?
Yeah, absolutely. And I will say that in the field of mental health, there are more people with like the social work and the counselor background than there are with public health professionals, but I think that's starting to change. And I will say that, so I got my Master of Public Health at UAlbany at the School of Public Health when it was called that. I had a job for about, a little less than 2 years that was not in the behavioral health space. So I say behavioral health includes like substance use, mental health, suicide prevention. And so then I ended up in a job at the New York State Office of Addiction Services and Support. So it's like the Office of Mental Health Sister Agency that we call OASIS. And that's when I got really into the behavioral health space. And because I have the public health background, I was always interested in the New York State Public Health Association, but trying to find that connection. So at the New York State Public Health Association, we call it NISPA. So I'm just going to start saying NISPA. But one of the flagship things is their annual conference in April. So I had wanted to present on some of my work I was doing at Oasis, and it just was not really a priority area of public health at the time. So I just continued kind of pushing my way, being a loud voice, and eventually I ended up presenting a plenary at their conference. So I thought maybe I could get a position on the board of NISFA and try to make a change. So if I get elected to the board, on the kind of platform that behavioral health is public health, I can start to make a difference in that space. And I did. So I was a board member for 3 years before running for the president-elect position. So at that time, it was your president-elect for a year, then president and immediate past president. So I got elected, but I've been president for 3.5 years now. So that trajectory changed a bit. So I'll be president for 5 years. But the good thing is that I made mental health and behavioral health a priority for a public health association, which is unique among all of the state affiliates of APHA across the country. So I think that, the main thing I'm trying to say is that behavioral health, mental health, these are public health, but not necessarily always seen that way. So the idea is that a public health professional sees things from kind of a community, a population approach. And a lot of things that we do in the public health field would be program planning, program development, implementation, and evaluation. Maybe instead of kind of working in a clinic or running a program, we look at where the gaps are and maybe bring projects in, bring funding in, and run multiple programs. And my area at my current job, Newark, focuses on behavioral health. I actually lead our behavioral health portfolio and have the projects coming and going at all times. And I'm currently leading 6 projects that are in this space in our public health department. So all very public health focused. So I would say that public health is very important. And I think that teams that work on mental health really benefit from having different lenses. So having public health professionals, social workers, people that are in macro and micro social work, psychologists and psychiatrists. So when I worked at Office of Mental Health, I was in the suicide prevention office, and we have people of all backgrounds in education. So I think that's like the most effective way to look at it. But I definitely have to keep saying that mental health is public health to really kind of you have to keep pushing at that. And I think some of my best achievements with NISFA would be starting a mental health work group and then pulling in key parties across the state to form the NISFA's statewide behavioral health advisory group, which does have representation from Office of Mental Health, from OASIS and NAMI and several other organizations across the state. So definitely I'm happy to chat about the people about it afterwards, but that's it.
Terrific. I can say as somebody else who's entered the system, I originally started emergency services and then got into public health and addictions, right? It's definitely an area that we need to see more of that overlap. And I think that's something that's great about the Rockefeller School, right? You have all these disciplines in the one school, and hopefully all the students here today get a feel of how there's that many paths in. We'll move on to Derek. If you don't mind sharing a little bit about your background, but also, veterans mental health has been a focus in recent years. How do you think that's changed? Or how does that change from a public policy standpoint?
Yeah, absolutely. And hopefully I can tie in both of those because similar to Liz, I kind of learned the hard way about how important mental health care is after I served in the Marines. I grew up in a family that a lot of folks had served, so it was something that was relatively common. But I actually lost my best friend to gun violence when I was 19, and literally just wanted to run away. And the Marine Corps was happy to have me. There were two wars going on. For me personally, again, once I got out, I think a lot of stuff started hitting me. My friend was killed in September 2005, 2004. By the next August, not even a year later, I was in Iraq. So really wild to experience community violence and then be on the front end of, imperial violence. So there's a lot of questions in my mind, a lot of things that I was dealing with. I turned to different organizations when I got out that really helped me kind of navigate what was going on, and then that kind of sparked the curiosity for me, like what can I do to others to help out? And I think to discuss how what's kind of changed from a public policy perspective. Back when I started doing advocacy like 15 years ago, it was very much like we need to increase mental health care for veterans because they're coming home from war and everything is very tragic and everything's everyone's traumatized, and of course there was some truth to that. But I think what has changed is now we're seeing veteran status as a social determinant of health, and we're realizing that yes, there are some war-related trauma and issues that need to be addressed. But that's usually just one issue that many veterans face. So to give you an example, things that are atrocious like military sexual trauma and assault, it's very common, but at least we're having the conversation now to explain that you could have PTSD that's not from war. You could have served in the military and been betrayed by people in your command, and now you have this moral injury, you have more complex issues, and that's kind of new. Where again, when we're talking about a veteran, we're usually thinking someone who experienced something brutal in combat, came home and struggled, and maybe had a drinking problem, very stereotypical views. And that's changed a lot. So I think that's good to understand, one, that the veteran community is not a monolith by any means, by any standard. Women are the fastest growing demographic in the veteran community. So as we're seeing the demographics change, we're seeing the conversation about what's causing these issues and how to address them. We're also seeing the policy change. So things like veterans treatment courts, which are novel, but it offers treatment in lieu of incarceration because folks started to realize, well, yes, there might have been something that was deemed, against the law, or maybe their substance abuse issues got them involved with the justice system. But maybe those issues stemmed from somewhere, and because veteran status, for one reason or another, is looked at as a population is worthy of this treatment, you have these options. And I think what's changing now is folks like myself, what we're trying to prove is that these programs don't work because we're veterans. It just works because we're human. And these are more humane ways to treat people instead of incarcerating them. So that's brand new from like a tough on crime approach that we've seen early on to, hey, maybe there's a reason these folks were acting out, or maybe there was institutional racism or discrimination that got them kicked out of the military without benefits. And maybe we can look at the root cause. I think seeing that change has been really, I think, progress for sure. A lot of that is backsliding these last few years in particular. But that's probably the biggest change I've seen over the time of doing policy.
Well, next time we do this, it'll just be myself and Derek talking about treatment courts from now for the full 2 hours. But we'll keep it moving. With Tracy, you mentioned that you previously worked for the governor's office. How do you think that experience has changed your work working at really one of the highest levels you can in New York State?
Yeah, it was a huge learning curve for me, a huge learning experience. As I said, I came from a clinical background. So full transparency, I knew very little. I didn't realize how little I knew about the policy making and legislative process until I went to the governor's office and got a really intense crash course on the budget making process and everything that is involved with that. Um, it was tremendously valuable. I think there's some similarities as well as a lot of differences. In terms of similarities, both my role here at OMH now and working at Executive Chamber are really trying to oversee operations to make sure that they're in line with the governor's vision and direction. And so making sure that all of the programs and funding and legislation that is put in place really achieves what her vision is. And hearing from advocates, stakeholders, individuals who've been personally impacted by behavioral health and trying to take all of their input and feedback to find opportunities to improve the service system. And so I think it's just different levels of how you're able to do that and impact change. At Executive Chamber, I was working very closely with OMH to understand what's succeeding, what do we need more of, what are the challenges in the mental health system, and what are the ideas to try to address and improve those. Why we need different statutory changes or regulatory changes, and the impact of some of the proposed investments that OMH was coming up with. And so it was a lot of getting information from the office and then trying to interpret it and explain it to the governor's team and really advocate for why some of those things are needed and necessary. Now that I'm back at OMH, it's an opportunity to kind of be involved in an earlier process in some of those like brainstorming opportunities and coming together collaboratively with colleagues to try to figure out what those solutions might be, and then bringing them to the governor's office and really fighting that fight to try to get them into state of the state or into budget, and really trying to help to move those things forward. And then I think also being at Office of Mental Health, we have more of a role then in the implementation of that. And so you get a general directive from the governor's office, but then it's our job to take that and really make sure that it meets the needs of the individuals that we're serving in the community. And so being able to have a role in that and have a place in that work, it has been that's actually what kind of connects me still to some of the social work and the direct practice that I used to do. So for me, this is a great balance because it still is enough of a connection to the community and hearing, the real life stories of the impact of the work that we do, which is really fulfilling. So both really tremendous opportunities, and both have their strengths and just great experiences all around.
Thank you for sharing all that. This of transparency, I may or may not have been one of those advocates coming to her advocating for policy. Uh, move over to Liz. We've talked a lot about how New York State operates, but you've worked in multiple states. Uh, how do you think New York's mental health policy differs from the states you've worked in?
I think on a very basic level, all states are trying to approach policy in the same way, in the sense that, we're looking to improve the lives of people who are residing in that state and their family members around, services, around access to treatment, around stigma, around rights. Uh, Having said that, again, although I have to say, Florida is a lot more progressive than I would have given them credit for after living there for 12 years. But New York, by far, we are a much more progressive state around things involving mental health and substance use and the intersectionality that goes with other systems people will find themselves in. I think we have a very supportive governor. We have a very tight-knit advocacy community that tend to be, for the most part, on the same page about the things that they're advocating for, which that was a distinct difference I've noticed compared to other states I've worked in, where you can have a lot of different advocacy happening that isn't aligning well. New York's almost always aligns together. I think that we have a very robust group of family advocates in New York State that are very vocal, NAMI being, leading that charge, but there are other advocacy agencies as well. But we also have historically a very strong rights movement known as the Consumer Ex-Patient Survivor Movement. New York really led the nation in that respect of folks who were coming out of deinstitutionalization and heralding back to times when state psychiatric facilities were viewed as asylums and just people, could lose their lives really, spend, living in a state institution. Like a lot of activism and advocacy came out of that movement that is still represented in the state today. It's not as large as it used to be, but it has shaped policy in a lot of ways for the state. One of which, sort of a simple thing but very impactful was people with lived experience were hired then by the state of New York in a civil service capacity to work as peer specialists within the state. Celia Brown is the first peer specialist that we ever had in the state of New York, who unfortunately she passed away a few years ago, but hugely instrumental. And because of her advocacy and her perspective, we now have somewhere around 85 to 90 peer specialists working for the state of New York, a few family advocates as well, a few youth advocates working in my department. And so it's always elevating that voice of lived perspective in the policymaking. So the way that we approach that is so multifaceted. My department specifically, we're the liaison really for community and government. So we bring the information from OMH to the community, as quickly as we can, but then we also seek to form relationship with people in communities who are directly being impacted by our policies, by our programs, by our services, gather their feedback and create opportunities for them to give that feedback, as Tracy was talking about, in multiple different ways so that it does make it to the governor's office, so that it can be in the state of the state proposal so that these initiatives can be funded. I mean, I don't think we're ever going to have enough money, and this governor is very generous around mental health, but the need is always growing, and there's always some, veterans, like, there's just so much, and there's only so much money to go around. So I think we are very, very ahead of the curve in that respect, that it comes together in a way that it doesn't quite do for other states.
I really appreciate your mentioning the incorporation of peer voices into the implementation. I know Tracy, you've talked about that as well with OMH and actually seeing the programs get done. As we go into Brett, one of the projects you worked on in the substance use disorder field is the SBIRT program. Can you talk a little bit about what that is and what it took to make that evidence-based practice like an actual policy?
Yeah, absolutely. So SBIRT is actually SBIRT, and it stands for Screening, Brief Intervention, and Referral to Treatment. And it's an evidence-based prevention and early intervention model for substance use. So essentially, I think it's like the protocol makes a lot of sense. And it's delivered in non-specialty treatment settings. So you think about people that have a substance use disorder may go to a treatment center to get assessed and see if they have a substance use disorder. But there are a lot of people out there who might be drinking, using other drugs. It might not amount to a substance use disorder. They might not know. And there's a big population out there. So if you think about the pyramid, like a pyramid, you've got the bottom where most people are, no or low risk. And then you have like the middle of the pyramid where you have like harmful or hazardous use. And then the very top where people have a substance use disorder. So in the past, you have this like prevention, complete prevention, universal prevention at the bottom, and then treatment at the top. And there's about 25% of the population that fit in that middle where they get really nothing until ultimately they might end up with a substance use disorder. So in the using a prevention and public health lens, you see that addressing it earlier on and preventing the substance use disorder is the best approach. So this SBIRT model, like the best example is implementing it in a primary care setting. So it's universal screening. So everyone comes in and they answer some questions according to a standardized validated tool. So it's a questionnaire. And it's not like, this person looks like they have a drinking problem, right? And then I'm going to ask them some questions. It's for everybody. So there's no stigma involved, and everyone feels comfortable asking these questions. It's part of standard protocol. And then the screening tool it essentially gives the provider a score. And based on that score, it tells them what type of care they should be delivering. Is it no risk? And if there's no or low risk, and then they get this kind of positive reinforcement. Or is it a low risk? Maybe they get some brief advice, or some a moderate risk where they get a brief intervention right there on site. So the providers there, it could be a health educator, a nurse, or the physician, or a nurse practitioner that provides a brief intervention based on an evidence-based brief negotiated interview. And that is, it can start off scripted and then providers get more comfortable delivering that intervention, but it's person-centered using the skills within motivational interviewing. And it's directed by essentially the person and looking at what the pros and cons of their use are, trying to push them essentially, but directed by them towards making a change. And then, if necessary, there is a referral to treatment. So the screening piece, the BI, the brief intervention, and the RT, the referral to treatment. So essentially, they would get referred to a substance use disorder treatment provider for further assessment. So this is an evidence-based practice. I wouldn't say it's implemented as much as we would like to see it implemented. And in my work, because I was working on this at Oasis. And then I went to the Office of Mental Health, working in suicide prevention, and we were doing screening, brief intervention, and referral to treatment for suicide risk. Now that I'm at NORC and I have a little bit more flexibility of not being in a state position, looking at the intersection of substance use and suicide and being able to jointly address these issues because they're so closely connected. We've integrated suicide care into the SBIRT model, and the model we call SBIRT SC, or SBIRT Suicide Care. And we've been delivering this quite a bit, actually, in some rural areas in North Dakota. Speaking of states, there's far fewer resources in North Dakota. So it can be delivered there, which means it definitely can be delivered in New York. And the most recent addition to that is working with older adults and addressing social isolation and loneliness through social prescribing. So we're now adding to the screening social isolation and loneliness, a brief intervention to kind of encourage older adults to accept a referral to some kind of program out in the community to get them engaged. It could be just kind of joining the YMCA, volunteering at a Rotary Club, reading to children at the local school district. And it could be a virtual activity as well. Like it could be volunteering with the New York State Public Health Association or with NAMI. So that's something new that we're rolling out. So I bring all of that up because SBIRT is a very flexible model. SBIRT itself is evidence-based. Suicide care, the elements of that are evidence-based. And social prescribing is evidence-based. The model together is not evidence-based. So we're working on evaluating it as a model together. Translating a practice to be evidence-based takes a long time and resources to do the study on it and to get that to be evidence-based. And then translating it to policy is even harder to do. So you definitely need to have patience and persistence. So when I was at Oasis, we look for incentives to get providers to deliver things like SBIRT. And one of the things is billing. So can a provider get reimbursement for the screening and brief intervention? So when I was there, I was on a work group and we developed the policy guidelines for billing in New York State for SBIRT under Medicaid. So that was an important policy that I was involved with. Then later, fast forward, I'm with the New York State Public Health Association. We often get people reaching out to us, or the governor's office reaching out to us to provide input on certain bills that come across the desk over there. And one of them was requiring SBIRT training. And like having Oasis have like an SBIRT training curriculum developed and prepared. And unfortunately, well, first of all, I knew that had already been done because I used to work there. So I'm like, you're proposing a bill for something that's already been done. So I mentioned that and I provided some suggestions about where the bill and the policy needed to be. And then the policy it never went anywhere. So you can see, I'm just saying like small wins are good. And I think that the fact that screening and brief intervention are billable services in New York State is a really good incentive to deliver that. And I think we need more. The best example, I think there are a few states out there that require screening and brief intervention of certain grade levels in school. And that is something that in my feedback, when I received that from the governor's office, I said we should be looking at that. And I know it hasn't happened yet, but that's something that I think it would be a great goal for New York State to have this as a requirement in schools.
Interesting. I'll have to follow up with you on that. But thank you for sharing all that about Esper and what it takes to get it out there, especially like that. One of the things about Esper is it gets it into these kind of non-traditional spaces, or it gets into like primary care offices, not just substance use disorder treatment offices. Its goal is to kind of overcome those barriers, which brings me over to our next question with Derek. The institutional barriers are often found with those social determinants that you mentioned, but they also kind of occur with different populations, and a lot of times they're co-occurring. So, what types of policies do you see addressing the issue of these institutional barriers with veterans access?
Yeah, it's a great question. I think one thing in particular I would say is policy that expands access to the Department of Veterans Affairs for their healthcare in particular. Anything that would allow that or drive more veterans to enroll or utilize that care. And one thing, I think there's this huge misconception that VA care is like antiquated and old and doesn't provide good services. And the exact opposite is true. So VA often provides care on par, often exceeding that in the private sector. It is like a research powerhouse. About 8 out of every 10 nurses, 7 out of 10 doctors train at a VA hospital. And one of the great things that it does is that it's a publicly held accountable because it's a public institution. So they're very transparent about a lot of the health outcomes issues they have. If you have if something happens to you at a VA hospital, like you can reach out to your senator or a representative. You can't do that if you have an issue with like a private provider. There are all kinds of things that would prevent like horror stories from private providers getting out because of NDAs or settlements and things of that nature. Whereas VA is a publicly held institution, so though not perfect by any means. Discrimination is much lower at VA for those reasons. They don't turn folks away if you're eligible. And there are all kinds of reasons that or legislation or policies that allow you to get care even if you're not technically eligible for crisis management, things of that nature. So one, I think driving more folks to VA would definitely prevent a lot of these barriers, institutional racism and discrimination that exist in our healthcare system in general. But then to flip it, as I think if we're looking from a policy perspective, there are places like North Carolina in particular that has a partnership with their VA hospitals and three of the largest health systems in the state. And they have an agreement to share data so they can compare health outcomes. I think most of us live in a relatively like monopolistic healthcare market where you kind of go wherever you can because that's where you have insurance, and you can only see a handful of doctors, and then based off of your schedule, et cetera, you don't have a ton of options. You really can't shop around. And one larger federal policy that I wish would get more attention is that since 2014, roughly, there's been a ton of federal legislation that has basically slowly been outsourcing VA care into the private sector. So when I started doing this work, about like maybe 1 in 5 appointments that VA would purchase would be in the private sector, and that would be because it was in a rural area, or maybe there was a specialty that the patient needed they didn't provide, so they would purchase it when necessary. But what we see now is almost like between 40% to half of all appointments are purchased in the private sector. And they're not sharing that information. So we don't know if they're getting better care. Likely not, because again, VA provides great care across the board. We don't know how the patients are faring. We don't know if there's communication between the two. So VA is relying on this care, which is also incredibly expensive. And we don't know if it's better or not. And what we do know is one, veterans on the whole have suicide rates that are about twice those of the general population, which are already elevated and have been over the last 25 years or so. But veterans that purchase or use VA care that's purchased in the private sector have even higher rates of suicide. So there's no accountability, and all of this has flown under the radar because it's under the guise of, well, veterans should have choice. They should be able to go to the private sector if they want. And I do agree with that if we're talking about getting similar care that's appropriate and what they need. So I think if we really wanted to reduce barriers and ensure that discrimination is eliminated, I think leaning more towards public institutions that are held accountable and then having these agreements with private hospitals to say, hey, if you're going to accept VA federal money to provide services to a veteran, you need to tell us that it's at least on par with what they'd be getting at VA. And then we don't have a better understanding of who's getting turned away from where, why, et cetera. But until that happens, we just don't know. And I don't think it would behoove us to just trust that this care is on par and working out for veterans. So those would be probably like my two biggest recommendations.
Great. I mean, thank you for sharing those. Those are obviously quite substantial barriers to access, and uh, barriers still remain, right? I guess it does lead us into our next question with Tracy. Given your roles, uh, what do you think is the biggest challenge right now in New York State's mental health system?
Yes. Unfortunately, I think the biggest challenge right now is what we're facing in terms of the federal government and some of the changes coming down at the federal level right now. I think we're in a time of tremendous uncertainty. We're seeing a lot of benefits being stripped away from people, as I'm sure people on the call have heard. There's been a lot of changes related to Medicaid, the Affordable Care Act, the Essential Plan. A lot of people are potentially losing their insurance coverage, and it's significant enough that it's something that New York State cannot fill that void. So there's things in this year's budget that hope to kind of patch that up and ensure that as many people as possible are able to retain their benefits. But there's still going to be people, I think close to 500,000 people, even if that goes through, that will lose their health insurance this year. There's a lot of non-citizens that will be losing all coverage. And with the current state that we're in, are going to be needing mental health services and supports more than ever, and probably reluctant to reach out to services or providers that they aren't already established with. There's a lot of fear in the community that we're trying to manage, and it's just a very challenging time for folks. There's changes to SNAP. People are at risk of losing their SNAP benefits, and there's work requirements that are being put in place, and new enrollment and eligibility requirements for SNAP and Medicaid, where people have to recertify more frequently. All of these things make it really difficult for our population, individuals who are living with serious mental illness, to maintain benefits and to not have gaps in care. It also makes it really, really challenging for our provider network, who are going to be working with people who are now uninsured, and they're not getting the funding that they need in order to continue to keep offering services. So I think that when we look at the coming year, those are the things that we're really going to be focused on at the Office of Mental Health. What can we put in place to try to mitigate some of that? How can we use the services that we already have to try to work with providers and work with individuals to keep them insured, to try to stay on top of these new requirements, these ever-changing things that are coming out of the federal level, and just provide education and support as much as possible, using technology to try to trigger some of these things and get ahead of the requirements. And then, housing. There was a recent notice of funding opportunity from HUD that stripped away a large portion of permanent housing. And although there's been lawsuits filed and things seem to be calm for now, we expect that there will be another NOFO coming that changes things again. And we don't know where that will land, but there's attention shifting away from housing first and moving more towards a housing options that are requiring or mandating certain levels of treatment, and just putting a lot of people at risk for potentially losing their homes, which if people don't have a home, then you can't work on your mental health and well-being. So our next year is really going to be working with our partner agencies, OASIS, OTDA, and trying to put as many plans in place to try to keep people safe, keep people housed, and keep their services in place.
Just a quick follow up on that. Can you tell everyone what NOFO means?
Yeah, sorry, it's a notice of funding opportunity. So it's basically how all of the continuums of care across New York State get their funding for HUD-funded housing units.
Great. So it sounds like from what you just said, as well as what Derek has contributed, advocates that have our work cut out for us. Uh, Liz, your role looks to organize kind of advocacy in the mental health system, whether it's the individual cases or more broadly. What do you think the biggest barrier to people getting involved in advocacy is?
Well, there's everything that was just mentioned. So that's a huge barrier because at the end of the day, if I can speak for myself, I'll use my own personal experience. So you're dealing with these challenges. For me personally, I've gone in and out of different degrees of wellness over the course of my life. And then you have to be an advocate for yourself on top of it, because if you let your guard down for a second, you're being stripped of your rights, you're being stripped of opportunity, you're being stripped of the ability to live life like everyone else, because there's a fundamental bias against mental illness that is in this country. The federal government is showing that, unfortunately. There are all the isms collide together, and it's just exhausting. It is exhausting. And it's a complicated, multi-layered system that we have in New York State, for example. That is a one distinct difference from other states. When I worked in Florida, for example, it was one. The Department of Children and Families and the VA, the veterans were here, but overseeing most was the Department of Children and Families. Here we have a lot of agencies and a lot of systems that come together, and folks struggle to navigate that. So systems literacy is probably one of the biggest barriers that we face. But then on top of it, it's the racism, it's the ageism, it's the ableism, and the stigma. We talk a lot about stigma, but the worst part about stigma is that it leads then to discriminatory behavior, and people are excluded from society and from being able to even be exposed to the same opportunities that other people might be having. When you talk about a public health approach, the general feeling in society is that people with a mental illness are dangerous and need to be locked away and put away from sight and get out of everybody's hair and way. And the media doesn't help that. They talk constantly about, the people pushing people on the subways. And I think it was you, Derek, who said, no one's asking the questions, what happens in someone's life that puts these pieces together in such a way that ends up being a behavior that someone engages in. No one's asking those questions. And quite honestly, general society doesn't care. So it falls on advocates, it falls on the individual themselves quite often and their families, and the burden of that can be tremendous, and you just get tired. When I worked for NAMI, I was running that family to family training that you all offer, and the support piece of that. And I heard over and over again from family members, I'm tired. I'm tired. I'm tired. This is confusing and I need assistance in figuring this out. Then you hear the same thing from the people with the direct experience themselves. So I think, there's a lot of room from a public health approach, honestly, to poke at that, to sort of look at the way society thinks about public health. And another piece of it that is a barrier is that when we talk about services and systems, we're not talking about it in a holistic communal way. It's about the individual directly. And so it sort of separates them out from any kind of public responsibility that they may have. What is your responsibility as a citizen living in whatever place, and how you're interacting with the world around you? Because not only do you isolate yourself and sometimes get disconnected because of what's happening internally, but then society's like, there's no room for you here. We prefer to not have to deal with you. So that's my personal, I've experienced that, and I'm a person of privilege at this point. I didn't always have that in my life. I do have that now, and I still experience it. So I think that that's a never-ending issue that folks are dealing with. What helps, though, is being able to connect to larger organizations like a NAMI, like the Alliance for Rights and Recovery, like Mental Health Association. There are very large or advocacy organizations that bring power in unity. And then you're all on the same page, you're all saying the same things, and it can alleviate some of that burden that people feel about trying to do it alone. Individual advocacy is always needed, don't get me wrong, and I do it on the regular, but it's that communal, combined effort of advocacy that tends to have the greater impact.
Yeah, I really love it. You said I've heard it said before, like people need to stop asking what's wrong with you and start asking what happened to you, right? And that's definitely something that we look at as we kind of turn more towards all the problems that we have going forward, but also going upstream, right, to the prevention side. Uh, going to Brett, prevention's become more of a broad focus, especially as we talk about some of these systemic issues that are barriers, but also systemic, like social predeterminants of health. What do you think people who want to work in this field should know about prevention and mental health?
Yeah, I want to tag on to something Liz just said, and I think it ties into what my answer is going to be anyway. But the points that Liz just made are really important and something that's also kind of on my soapbox. And I come from the public health space, and you were just listing these larger associate advocacy organizations. And I think we in the behavioral health space, we all think a certain way, and we think we're in our bubble, and we think everyone thinks that way. That's the public. But you step out into the general public, and that's not the case. So I think that's a really important point. And what I bring in terms of public health is a broader group of professionals, and we need to educate that broader group of professionals about how to support individuals who might be living with a mental illness or really anything, and how to talk about mental health, and then work with the populations that they work with, which is often a broader population than the behavioral health field works with. So I think that generally speaking, you wouldn't think of the New York State Public Health Association as a group to partner with in this effort. And in my role as president, I'm trying to change that. So that's why I set up that statewide behavioral health advisory group, so that all of these entities, the ones you listed, are all on that group. How can NISFA support that and bring this to the larger professional group and then to the larger population? So I think that that is really important. And these, stigmas are out there on so many different levels, including the people that are supposed to support the community, like all the way up to the local legislators. So if they don't want to see these services in their community, because they don't want to bring those people in, those services won't be available. So there's just so many different levels of that we need to work on. So I think that students should know that public health plays a major role. So there's so many ways to get involved in mental health, and public health is one of those. So I don't think like people go, I'm going to pursue a master of public health. There might not be a lot of opportunity or a lot of coursework in mental health. So I think that it takes kind of a persistence to pursue that, maybe finding the right internship. For myself, I finished my Master of Public Health program. I had nothing in mental health. I wasn't thinking about mental health as a career. I only ended up at Oasis because the job posting and it looked interesting and I applied and I got it. And I really loved the work. I thought it was really important, and I felt that I was contributing something important to society. So I ended up staying in that field from near the beginning of my career throughout. And then so I went back to the University of Albany for my doctorate of public health. I focused on SBIRT, what we just talked about in the last one, the last question, and continued that work, throughout my career. So I also want to add as well to something that Tracy said, because I think we need to think about what situation that we're in coming down from the federal government and what that means for the job market. So I don't want to scare anyone, but it's a very difficult job market, and I think students need to know that. So it's really important to have a diverse and transferable set of skills. So I think there are many different ways to build those skills. And I think you can get them in your degree program or your certificate program, and you can get them through volunteering in different organizations. So like NAMI is a perfect place to volunteer. The New York State Public Health Association, we have people joining all of our committees, and we engage in all these different things, including policy. We have a policy and advocacy committee. So there's all these different ways to build that and also build connections. And I also think looking at things in a broad way. So maybe you're interested in policy, but maybe you want to also think about program development or evaluation, because a lot of these things interplay with each other. But you also want to make sure that you kind of jump on different positions because we're, in a time, unfortunately, in a time where there's not as many options available. And I think prevention is important to think about because what does it mean to be working in the mental health field? And if you wanted me to specifically say where my greatest focus area is, it's suicide prevention. So one of the projects I just talked about earlier was addressing social isolation and loneliness and supporting social connection among older adults. And when we went to get that work, we had to bring funding in for it. The focus of that statement of need was on suicide risk, and particularly in rural areas where the focus of the project is. And that is, I mean, address a social connection is a big protective factor for suicide. So that is essentially, in my eyes, suicide prevention. It's a prevention approach. So I think having that wide lens is really important to thinking about how you could potentially work in the mental health space.
Well, really appreciate sharing all that, especially the need to get more folks encompassed. I spent a bulk of my career working to get EMS, police, fire agencies to better respond to behavioral health. But you kind of touch on something that I want to follow up with there on in the final question here. Uh, is the In recent years a lot of the call for veterans' perspectives in mental health, and they're not alone. Other social issues have had the moniker of "nothing about us without us." Should a person entering public policy, you know, what should somebody entering public policy with that kind of lived experience know about how to share that?
Yeah, also a great question. I think one thing to throw out there is, folks with that experience, I think it's often one of the best things to like best tools an advocate can have, just to make that relatable. I think that always helps, but I would just caution to like make sure that you are like protecting your peace and you're taking care of yourself in that work, like in general. But kind of back to your first question, like one of the things that changed, and I hope that this is like a permanent change, but like especially in the veteran space, like everyone wanted you to like tell your war story, like your worst day on deployment, etc. And that was like a common thing, and it was effective. We used to do that in DC all the time. But at the same time, no one was telling you like to take care of yourself or like what to be mindful of. So I think this work in general is very demanding, very challenging, often tons of setbacks. But then if you are this is something that's near and dear to your heart, and you have a personal connection to it, I think it's just super important to just take care of yourself. And again, that's like true across the board, but that's like the best advice I could give because a lot of these policy routes, if even if they're successful, take a very long time, and something that's it's a huge time commitment and emotionally can be draining. So that would be the my one big takeaway is definitely, be mindful of, your own well-being and take care of yourself to the extent possible.
Great. So Liz beat me in the chat about interns. I know OMH and a lot of state agencies. I used to work for Department of Health and DCJS. I know they have internships as well. But NAMI also has a Next Gen Youth Development Program. So there's a number of ways that you can get involved going on from here. So feel free to reach out to myself or any of the panelists. We do want to give you all some time to ask questions. Feel free to raise your hand and we'll call on you to take yourselves off mute and potentially ask any of the panelists questions. Okay.
Yeah. Looks like we have one from Shantae. So go ahead.
Hi, I just want to thank you all for being here to begin with and for sharing your experience and knowledge about the field. I have a few questions that's kind of compacted into one. So I was wondering how, like, does being an MPA student change or affect someone's ability to get into the field? And what are some limitations, and how can someone increase the odds of finding a career in health services or mental health services if they have an MBA? I do have a background in psychology, and I'm planning on making my own concentration in health policy. And I just wanted to know a little bit more of how to possibly get into the field.
I can answer from the state perspective that there can be limitations sometimes on whether or not the civil service has deemed a degree appropriate for the role that you're applying for. And so, for example, we had some folks who were doing peer work in a state PC that had a bachelor's degree in criminal justice, and they were looking to go into a rehab-oriented role, and that background did not apply. Like they weren't actually even able to apply for that role. So I think that that's really smart to be thinking about that because I loved that I got a master's degree in health advocacy, but it's enough. I can't bill Medicaid with that master's. So I locked myself out of a lot of other potential opportunities in direct service because of that. So I think that's a good question to be asking. But we have folks with public health backgrounds all over the agency, though. It really just would depend on the role that you were applying for and what you were looking to do.
I can jump into that as well. We've had state, like, I guess they're essentially state positions run by like the fiscal agent, so like the Research Foundation for Mental Hygiene at OASIS and the Office of Mental Health, and then Health Research Inc. at the Department of Health. So that kind of takes a little bit of the strictness away of what Liz was talking about. So when you're looking for jobs, I would suggest looking at those websites as well because there's plenty of positions open there. I think the master's degree, whether it be an MPH, an MPA, or what it might be, is really critical in the job market. So you will see a lot of jobs asking for a master's degree. A lot of them will also ask for 2 years of experience as well, which is a challenge. So you need to get that experience somewhere. So something I like to tell people, upon graduation is that you might not always fall into your dream job right after you graduate with your master's degree. But you get that job, you get those years in, and then you spend time looking for where you want to be. So I said earlier that I had a job for just under 2 years before I ended up at Oasis. That was what it was not my dream job. It was not in behavioral health, but I ended up where I wanted to be, and I was able to spend the rest of my career. And I think that the public health degrees do give you a great set of skills. So think about what skills you're building beyond kind of what topics you're learning about in your classes. But then I think program evaluation is a really important skill to have across really any type of role, as well as program development and grant writing. So I think those are some really critical things that could get you some skills that would be transferable to any type of job.
And I would just add on to what Brett said in terms of your dream job too, and say that sometimes you don't actually realize what your dream job is until you take some of these other jobs that you don't think are your dream job, and they end up really igniting a passion in you that you didn't know that you had. So when I went for my MSW, my focus was in geriatrics, and all of my internships and studies were to work in skilled nursing facility settings. I have never done that a day in my life. And while I thoroughly enjoyed those experiences, I was able to take opportunities that were opened up to me in a variety of different populations and organizations. And I think that just taking advantage of those things that may not necessarily align with where you saw yourself really makes it you so well-rounded and really just expand your knowledge base and what you're able to contribute. So I would just say, take advantage of the things you don't know that you want to do, even if it's scary. And it just makes you that much stronger of a candidate.
Great. Thank you all for sharing. We'll move on to the next person, Gino.
Yeah, hi. Just want to say thank you for the presentation. Everyone was sharing something lovely. I heard some really passionate stories. Greatly appreciate everything that was said. But I want to ask a bit more personal question. What would you guys do if you guys were, back 18, 19 years old again? What would you guys do differently?
Who wants to take this one? Uh,
I
Yeah, I
can
saw some
jump in.
reactions.
I can jump in about one thing because the theme around some of my questions were public health. And when I was 18 years old, I didn't know what public health was. No one had mentioned it. So I went to college pre-med. And I pretty much, I mean, I did all of the pre-med requirements and I took the MCAT and I just realized like that wasn't my dream job. And then I took a course. I was taking one of those like extra courses in college that I thought would look good for med school. It was a medical ethics class. And there was this one class on public health, and I was like, I think this is it. Like, this is what I'm interested in. And I looked it up, and there was all these programs. UAlbany had this great program, and they had an internship program connected with the Department of Health. And I'm like, this is like a can't miss thing for me. This is what I want to do. So I mean, I literally had no idea. So like my whole college was based on pre-med. But I went to Cornell, and we had like a really, I was in the College of Human Ecology, and they had some really good courses like on social policy. They had like a policy analysis and management program. So I was taking a whole bunch of courses in that, and then these like a mix of biology and psychology classes. So I kind of got this interest in behavioral health and this social policy, and I think everything played together to get me where I am. So, um, and then I did want to mention one other thing because we have a few people here from the state, and I worked for the state as well. And when I was in the public health program, we always talked about state jobs, and they were particularly with the Department of Health, but still, state jobs nonetheless. So I spent 11 years between OASIS and Office of Mental Health, and I was looking at when I was ready to leave the Office of Mental Health. I was looking at, so what do I want to do now? And I was looking at Department of Health. I was looking at another position at the Office of Mental Health. And then I was thinking about non-state work. So we didn't really talk much about different types of sectors, but my day job is with this organization called NORC, spelled NORC. And we're like technically these like contract research organizations. We have a lot of federal contracts, state contracts, but I'm in the public health department, and I lead our behavioral health work. And I have work at in other states like North Dakota. I have work in New York State. I have work with local counties in New York State, and I have national work, including with NAMI National. So I think that it's something to consider. And the good thing about organizations like this, I think in the world that was before a year ago, like when funding was more certain, we were able to yearly bring in recent grads, and there's a professional ladder. So we have some people in my organization that came in with their bachelor's degree, or that some come in with their master's degree and have moved up through the ranks up to the senior level. So there's a lot of like professional development that happens, and there's a great like process for young people and recent grads to come in. So I would look at organizations like these. Their headquarters are all over the country, but they have people working remotely. So my organization is out of is affiliated with the University of Chicago, and I'm in Albany. So anyway, it's definitely something to look at if you're, as you're looking at options. And the reason I brought that up to your question is because I had never ever thought about that before at the age of 18.
So
Thank you.
I'll add one thing, and then we'll get on to the other questions. I see two more hands raised. One of my jobs was working for the New York State Bureau of EMS, and I did data work for them. So I learned to code in HTML. And one of my jobs was doing substance use disorder prevention, and we created advertising, and I had to buy campaigns for local movie theaters. And I originally went to school for nursing, and 2 years ago I was working for the New York State Senate. So you never know where those weird transferable skills will take you, and don't just assume that because you work in a field that that's exclusively what you're going to do, because you're going to find that when you're doing community work, you work in a community. You're going to be everywhere out in that community. So volunteer, follow the programs where they take you, and keep going. Move on to Emily.
Hi, everyone. Thank you so much for all of your insights. I had so many questions that I wrote down, and you would all answer them right as I wrote them down. So I appreciate that. Just tells me how informative this has been and how great the facilitation has been. So thank you. I think one of the remaining questions I have, so I currently work for the Office of Mental Health as well. I got in halfway through my MPA program. So to answer a question earlier, it is definitely possible with an MPA. I've seen a lot of people in our executive leadership with MPAs after their name. So I think that's very encouraging, but the imposter syndrome definitely creeps in. So I think one of my questions is, I have a background in nonprofit work, and I know a lot of you have that experience before getting into the more macro world. And I'm curious how you, as you get more into the macro world and the policy development, how you remain grounded with your communities and balance kind of the bureaucracy with advocacy. Liz, you said you're still an advocate, and that's something that I aim to always do. I'm also a family member with a sibling with lived experience, so I'm curious how to navigate that kind of balance between policy development, macro bureaucracy, and advocacy.
Emily, do I know you?
Yes, I
I
work on the incident review panel.
do, right? Okay. Yeah, I was like,
Yes.
yeah, okay. I love that question actually because I think about this a lot about, particularly when it comes to things that are outside of OMH's purview or control, and just see like the different messaging and some of the barriers that get in the way for folks, and I think to myself like how am I staying grounded? And I working for government isn't for everyone. Like if you are someone who wants to see quick results for your advocacy, you have to have patience in government. There are some things we've advocated for that took 15, 20 years to make them become a reality. I tell all staff that I'm hiring and onboarding, this is a slow burn. And you have to find a way to sort of reconcile that with what advocacy looks like in nonprofit world where, you can sometimes move the needle quicker. That's not to say that things don't also move fast in government because they can, but generally speaking, those tension points that people are always advocating around, that those things can take a long time. So I connect to community as often as I can. I connect to the people that are my natural supports as often as I can and try to remember that I actually have hobbies and activities that I enjoy and go do those. Lately, that feels like even more of a privilege, to be honest, to be able to do that, given what's happening in certain parts of the country right now. And I try to also wake up and say thank you that I can even still have that thought because there are people who can't. So
Mr. Derek, I don't know if you want to answer that as well. I'll just put you on the spot.
No, sorry. I think I feel like that was very succinct. Thanks.
Thank you.
I wouldn't mind a quick response to that just because I've been in the state and then left the state. So there are really positive things about working in the state, but of course, things are slow and there is a bureaucracy and there are priorities and you can't necessarily go out of those priorities and something that is a priority might change. So you're definitely have to stay within those lines. I mentioned Newark. I moved outside of that, and there's a lot more freedom. So I think it's where you work, and there's also a lot of kind of diversity of projects that you can kind of pick what you're doing if you're able to bring that work in. Even also, some people are really invested in behavioral health, but don't want to be focusing on that all of the time. So they might have maybe 50% of their work focused on behavioral health, and they might be focusing on something else in the public health field. Could be like teen pregnancy prevention or something. So you have a little bit more flexibility on what you're doing. So I think I would definitely consider those things as well. But I do think that so that I always plug, I have to plug the New York State Public Health Association, but I work in this national organization. And I tell people I like to stay grounded in New York State and locally, and I get to do that through the New York State Public Health Association. So you're working and doing some volunteer work in committees. We have a mental health work group. We have a policy and advocacy committee. We have a public health and action committee. We have a climate change committee. So all these different ways you can get involved in advocacy and action kind of right down at the local level without really any bureaucracy. So kind of looking at different options.
We'll take our next question, Sydney.
Hi guys. Thank you guys so much for sharing all this wonderful information. Um, so I'm a junior at UAlbany and I'm double majoring in psychology and human development, and I'm really looking to become a counselor or a therapist, and I know that that field can be really intimidating and, you know, kind of a lot to take on, and I just wanted to know what are some things that I could be doing right now? Are there any programs that I should be looking into to get me closer to that goal?
I'll jump in and say I think that you're actually entering it at a great time. We are in desperate need of more mental health clinicians, all types of clinicians. So I think that you're entering at a really good time to be able to have opportunities and be able to kind of test things out and see where your passions lie. And I would just say, network internships, just try to get connected as much as possible now, and get your foot in the door places, which I'm sure you're already doing. And I know UAlbany has great internship opportunities, but trying to find placements that align with your interests, and then really, like I said, kind of putting, reaching out and spreading that web and making sure that you're connecting with as many people as possible in that role, and getting the word out.
Just quickly ask you, are you familiar with Middle Earth at UAlbany?
I'm a little bit familiar with Middle Earth at UAlbany, yes.
Yeah, you might want to think about potentially being trained in that and becoming a peer, I'm not sure what they're called necessarily, but a peer counselor on that,
Mhm.
because that could be a really good experience. And I know that the people that run that also have a grant. Well, they have several grants that fund work with peer navigators addressing substance use, gambling, and suicide risk. So they have a significant amount of training for these peer navigators that then speak with other students on central areas of campus to identify any risk and provide brief intervention. So I think, I mean, if you want to, I can put my email address in the chat. If you want to connect with me afterwards, I can connect you with those people if that's something of interest, but don't feel obligated to reach out. But if, if you're interested, definitely send me an email.
That would be lovely. I did look at that because that was something that I was looking to do. But I think what do you know when the applications start? by any chance if they have any applications for the spring? I know that I think there was a deadline for November that I unfortunately missed. Is there any other times that they're opening for that?
I'm not sure. I think the best way is to actually make that personal connection to these people. Like I actually worked with an MPH student at UAlbany and got her connected, and she got into that program. And they do some research in the psychology field as well. So she got involved with that, and she thought it was a great experience for her. So I'm not sure. Like I haven't looked to see when the applications are, but it doesn't hurt to make that personal connection.
Thank you.
I'll also make the quick plug. There's a NAMI on campus chapter at UAlbany as well. So we're close to 6, and I don't see any more hands raised, so we'll call it there. Thank you all for coming, and we hope that it was very informative.
I'll just, it looks like there was one final comment from Gino in the chat asking about whether LinkedIn profiles or contact information could be shared. Depending on the comfort level of the panelists, I'm happy to provide any information to the students who RSVP'd and attended following the event, or you're welcome to drop it into the chat too.
Yes, give us 1 second. I'm getting my LinkedIn.
I'll go ahead and stop the
I'm
recording.
probably the only person who doesn't have a LinkedIn.